Welcome to the Department of Medicine Grand Rounds. This nice fall day. We're very pleased today to have Dr. Jackie Solomon, who's going to talk to us about multiple sclerosis, and Dr. Jim Salas, who's probably known to all of us, Head of Service of Neurology at Hamilton Sciences and Division Director of Neurology at McMaster University, will be introducing Dr. Solomon and facilitating the rounds. Dr. Salas?
Great, thanks very much. It's a real pleasure to introduce Jackie. I think many of you have had a chance to work with her, but for those of you who don't know, Dr. Solomon is an assistant professor in the Division of Neurology within the Department of Medicine at McMaster. She's one of our multiple sclerosis specialists. She completed her internship actually at Johns Hopkins in Baltimore in internal medicine, and she did her neurology residency at the Mass General and Brigham and Women's Hospital in Boston. And her fellowship in MS was nearby at St. Mike's in Toronto at U of T. She's had a long-standing interest in medical education. She first joined us as a clinical scholar and was instrumental in cementing our full accreditation within our division of neurology, within our program, neurology residency training program, preparing for that. And her specialty within multiple sclerosis and neuromyelitis optica spectrum disorder has resulted in publications in several journals. She's also implemented neurological emergencies sim curriculum for our neuro residents at McMaster that happens in the summertime for our trainees. And she is a back-to-back winner of the Division of Neurology Teaching Award. Very seldom do people win 2 years in a row. It's testament to her expertise as an educator and how much the trainees appreciate that level of expertise. So with that, I'm going to hand it over to Dr. Solomon for her talk on MS from bathtubs to B-cell therapies.
Okay.
Jack, take it away. Yeah.
Thank you, Dr. Salas, so much for that very kind introduction, and thank you, Dr. Azam, for having me. I'm very honored to give this medical grand rounds in an area of medicine that has seen massive developments in the last few decades, so I'm excited to tell you a bit more about that. We're privileged to provide care on lands that Indigenous peoples have called home for thousands of years. We recognize and respect the presence and stewardship of all Indigenous peoples as keepers of this land. So here are my disclosures. So in terms of an outline, I'll be first taking you through a brief history of the field of MS, and then we will look at how the MS diagnostic criteria have evolved over the last century to our very newest criteria that were just published. We will then talk about the spectrum of MS disease, and I will highlight a few recent advances in neuroimaging. We will then look at the treatment landscape of MS and how that has continued to evolve. And we'll talk a little bit about silent progression. And finally, we'll discuss a few experimental treatments that are currently being explored. And we'll finish up with a few pearls for the non-neurologist to know about MS. All right, so to start off with, MS was a very difficult disease to coin. Symptoms varied widely and could be localized to different parts of the central nervous system, and that made it difficult to unify the symptoms. But using his clinical observation and knowledge of anatomy and pathophysiology, French neurologist that many of you know by name of Jean-Martin Charcot, he realized that these symptoms that seemed unrelated belonged to the same disease. And so he named this sclerose en plaques in 1868. And almost 100 years later, that became multiple sclerosis. So the name multiple sclerosis is actually short for multiple cerebrospinal sclerosis, which refers to the numerous lesions or sclera that develop in the white matter of the brain and spinal cord. So here you can see, let's see if my mouse works. Yeah, here you can see an original drawing from Charcot's notebook. And that illustrates the center of a sclerotic plaque. So in the center of the preparation, you can see a blood vessel, and that's covered with many nuclei on each side. You can also see some demyelinated axons. So fast forward a few decades later, and a German neuro-ophthalmologist by the name of Wilhelm Uthoff, he notes that some of his patients report that their visual symptoms get worse when they're exercising. And initially, he links these worsening symptoms to the exertion of exercise, but it later became clear that the effect was caused by an increase in body temperature. And this later became known as Uthoff's phenomenon. And the idea behind this is that even a very small rise in temperature is enough to slow down the conduction of a nerve impulse along demyelinated axons. But the diagnosis of MS remained very challenging for a while. This now recognized principle of heat sensitivity became quite useful to help with the diagnosis. So even in the 19th century and even a good part of the 20th century, long before we were using MRIs or even using LPs very much, physicians used this principle to their advantage with a test called the hot bath test. So many hospital wards were actually equipped with a bathtub, and patients would be submerged in hot water. Clinicians would then observe how the patients acted when they got out of the bathtub, and they would look for any worsening of their neurological symptoms, which would then provide evidence that they had MS. So while this test usually produced transient neurological deficits that resolved when they returned to normal body temperature, there were cases described where their neurological deficits became more prolonged and more debilitating. There were also some cases of fatal hyperthermia described. So obviously this wasn't considered a very practical or safe test, and we don't use this anymore. So the first attempt to establish a set of diagnostic criteria was also by Charcot. So he published what now is known as the Charcot triad, which consists of nystagmus, intention tremor, and telegraphic speech. And then later, Schumacher made the first attempt to actually standardize the criteria in 1965 by introducing some fundamental requirements that we now use, including dissemination in space and dissemination in time. And these requirements were later inherited by Poser and finally the McDonald criteria, which we use today. So these Schumacher criteria for MS relied on 5 basic principles, which do continue to be very important even today. So we'll go over each one of these briefly, as they do remain the cornerstones of MS diagnosis. So the first important principle to know about is in order to even apply the McDonald or the diagnostic criteria, the patient has to have had a syndrome that's typical of demyelination, typical of a relapse in relapsing remitting MS. And this could be something like optic neuritis, a cerebellar syndrome, a brainstem syndrome, or a spinal cord syndrome with transverse myelitis, with symptoms usually following a course of progressing acutely over hours to days, then reaching a plateau over weeks to months, and then slowly improving. In fact, the McDonald criteria that we use have only been validated in patients with a typical MS syndrome in order to preserve specificity. If the presentation happens to be less typical, then you would have to confirm it with further paraclinical testing. It's also important to have objective evidence of central nervous system demyelination, which can be proven either by neurological examination or paraclinical testing. So this is not a comprehensive test, but I just wanted to list some examples of things you can look for. So for instance, in someone who's had optic neuritis, you might look for a relative afferent pupillary defect or optic disc pallor on exam to support this, or you might send them to a neuro-ophthalmologist who can do optical coherence tomography to confirm that they had an optic neuritis. For someone who had a transverse myelitis, you can look for a sensory level on their exam or a positive Lermite sign where the patient has tingling down their spine that's reproduced with neck flexion. And so on. You can look for abnormal eye movements in cerebellar and brainstem syndromes. Importantly, when we review the MRI of the brain and spinal cord, we have to really ensure that the lesions we are seeing correspond neuroanatomically to the past or present symptoms that the patient has. Another fundamental principle that we currently still rely on is dissemination in space, which basically means that we need to prove either 2 clinical attacks separated in space in the central nervous system, or 2 lesions in 2 different central nervous system locations, which up until recently in 2017 included juxtacortical or cortical location, ventricular, infratentorial, or spinal cord. You may note that the optic nerve is not included on this list of topography for dissemination in space, despite many patients actually presenting with optic neuritis. And this has been a great area of controversy ever since the 2017 McDonald criteria have been published, and there have been a lot of hot debates around this topic. In addition, you have to demonstrate dissemination in time. So I'm just going to wait for the announcement to finish. Okay. So it's also important to demonstrate dissemination in time with either 2 clinical attacks occurring at different time points, or it can be demonstrated with paraclinical evidence. So you can have an MRI that shows a combination of 1 contrast-enhancing lesion that would imply there's a new and active lesion, as well as 1 non-contrast enhancing lesion that would imply that it's an older lesion. Or you can prove this by showing a new lesion developing on a follow-up MRI. As well, CSF-specific oligoclonal bands have been shown to be an independent predictor of a second clinical attack. So the presence of oligoclonal bands in the CSF may also count towards dissemination in time. Finally, just as in any other disease that we diagnose, there has to be no better alternative explanation to the symptoms and the MRI findings. So there are a number of red and yellow flags to consider. For example, the McDonald criteria really have not been validated in certain populations, such as the very young and slightly older, and as well as in non-Caucasians. So in these groups, even if someone were to present with a typical MS syndrome, you do have to exercise caution and think of other mimics that may be more common to these groups. There are other atypical clinical and paraclinical features to watch out for as well, such as hyperacute onset of symptoms that may imply more a vascular disorder, or symptoms that are short-lasting or fluctuating that are not typical for MS relapse. In terms of paraclinical testing, if you don't see development of new MRI lesions over time, that's a bit unusual. And then looking for unusual features on the CSF profile as well can clue you in. So although we have traditionally classified MS into the categories of relapsing remitting MS, secondary progressive MS, and primary progressive MS with the typical courses that you can see on the right-hand side, we know that these subtypes are generally not actually so distinct and can have a lot of overlap, both in their pathologic features and disease mechanisms. Classically, primary progressive and secondary progressive MS have been defined as progressive disease without any relapses. However, we do know that relapses and new MRI activity can occur in both of these. Similarly, patients with very early relapsing remitting MS can have background disease progression even before they've had any relapse or if they haven't had many relapses. So we do know that relapsing remitting MS, primary progressive MS, and secondary progressive MS are really more part of a disease continuum with an indistinct boundary. And these underlying mechanisms driving the transition from relapsing remitting MS to secondary progressive MS have not been that well established. Moreover, in the last few decades, we've also come to understand that the spectrum of MS does not start with the appearance of the first clinical symptom. It actually starts even before that with a preclinical phase known as the MS prodrome, when patients may start experiencing nonspecific symptoms such as fatigue, brain fog, urinary dysfunction, etc. Many patients today happen to be incidentally discovered to have demyelinating lesions on an MRI when they're imaged for other reasons before they even have their first attack or progressive disease. And these patients often do go on to develop relapsing remitting MS or primary progressive MS. Sometimes we may catch people after they've had only a single attack, but they don't quite meet the McDonald criteria for MS, and we call this a clinically isolated syndrome. The more we learn about the MS prodrome and radiologically isolated syndrome, the more we're asking ourselves, is this simply early MS? We know from longitudinal studies that about 50% of people with radiologically isolated syndrome will progress to clinical MS in 10 years. And we've been able to capture the predicting factors of conversion to clinical disease, with spinal cord lesions being the strongest predictor. Interestingly, we see that the degree of brain atrophy in radiologically isolated syndrome is similar to what we see in clinical MS. And we also know that patients with radiologically isolated syndrome often have many symptoms that we see in MS, such as cognitive deficits, bladder dysfunction, and fatigue. There was a large study that showed that healthcare use in 4 Canadian provinces was higher in the 5 years before MS onset, before the first demyelinating event, compared to a population-based matched cohort, especially in the 1 to 2 years before MS diagnosis. Patients who later went on to develop MS had more hospitalizations, more doctor visits, and prescriptions filled. So this does beg the question of whether these demyelinating lesions on MRI are truly incidental because we're imaging people for different reasons, or are patients simply getting imaged because of this MS prodrome and the symptoms they're having. It's also important to note that we are getting better at diagnosing MS because the field of neuroimaging has seen remarkable advancements over the last few decades. So MRI image resolution has improved a lot over the years, from lower field strengths of 1.5 Tesla to 3 Tesla to now 7 Tesla. And to demonstrate why this matters, so take a look at the left-hand side. These are identical MRI slices using 1.5 Tesla MRI on the left and 3 Tesla on the right. You can see that the 3 Tesla MRI is able to identify one more juxtacortical lesion where the arrow is pointing, compared to the left-hand image, the 1.5 Tesla MRI. So obviously more sensitive in detecting demyelination. And the 7 Tesla MRI is even better at detecting a higher number of lesions compared to the lower field strength MRIs. And this is usually true mostly for cortical lesions. So for many years, we thought that MS was more of a white matter disease. But with advancements in MRI imaging, we see that's actually not true. So you can see on the right-hand side with the 7 Tesla MRI that it's able to detect a few cortical lesions where the arrows are pointing that you cannot see on the 3 Tesla MRI on the left. In addition, there are 2 MRI biomarkers that have emerged in recent years that can help with MS diagnosis. So the first one is the central vein sign. The idea behind this is that MS lesions like to form around veins and venules, which leads to a perivenular inflammation. And what you should see is a vein that runs through the lesion. So you can see here a nice vein running through the lesion, and here it's a little bit more enlarged. The central vein sign can help differentiate white matter lesions from MS from white matter lesions seen in other diseases such as ischemic disease and migraine, which can often be difficult to distinguish on a conventional MRI. And it's very useful because it's highly specific. The second biomarker that we're using now from MRI is paramagnetic rim lesions, or PEARLs. These appear as lesions with a dark rim around the edges. You can see here on the bottom right. And that's because of deposition of iron in microglia and macrophages. And that's often seen in smoldering inflammation that we see in MS progression. And again, these are useful because of their high specificity to distinguish MS from other entities, such as we see here with systemic vasculitis, where you do not see that paramagnetic rim lesion. So as we see the diagnostic criteria evolve over time, we can see that CSF was integrated in the criteria in 1983. In 2001, we finally started integrating MRI into the criteria, and this became the first iteration of the McDonald criteria. In 2017, we started using oligoclonal bands as an alternative for dissemination in time. And fast forward another 7 years, and we've now introduced several new biomarkers into our criteria that we'll talk about soon. So this is a summary of the 2017 McDonald criteria, which we were using up until now. As you can see, very complex, gives most people a headache to try to sort through it. So we were very excited when last year, the 2024 McDonald criteria were announced and were just published a few weeks ago. These criteria aim to diagnose MS earlier and more easily with less misdiagnosis. They focus also on differentiating MS from other disease entities with incorporation of paraclinical tools to prevent misdiagnosis. So what hasn't changed is that several basic principles still apply. We still need to have a typical demyelinating syndrome to apply the criteria. There should still be no better explanation. Dissemination in space is still required, and brain and spinal cord MRIs remain the most useful tools for diagnosis. So what has changed? Before, MS could be diagnosed without MRI, with only clinical history and exam, but now paraclinical evidence is required to make a diagnosis of MS, with abnormal MRI showing typical lesions to make the diagnosis. We've now introduced 3 new paraclinical measures to increase the specificity. So as talked about, the central vein sign, the paramagnetic rim lesion, as well as CSF kappa-free light chains. This is something that's deemed interchangeable with CSF oligoclonal bands and more readily available in certain institutions, and so therefore can substitute it for diagnosis. This is a big deal. Radiologically isolated syndrome can now be diagnosed as MS in specific situations if dissemination in space can be proven, as well as dissemination in time or presence of several paraclinical biomarkers. And so this reflects the fact that we are trying to move towards a biological diagnosis rather than a diagnosis based on arbitrary designation of disease categories. But obviously this has huge implications, as you can imagine, because now we'll be diagnosing MS at the subclinical stages of the disease. And this opens up a lot of new treatment decision dilemmas for these patients. Do we treat all patients with radiologically isolated syndrome with disease-modifying therapies? Can we even get insurance approval for these treatments at this stage? And are we going to capture a number of patients who actually don't have MS at that stage? Because a ton of evidence has emerged over the last 7 years to support the optic nerve as a crucial area affected in MS patients, the optic nerve will now count as a 5th topography for dissemination in space, which can be assessed using different modalities, either MRI, visual evoked potentials, or optical coherence tomography. Dissemination in time is no longer required to make a diagnosis in some cases of MS when you can prove it differently, but it still remains useful. And more stringent diagnostic criteria have been proposed now for patients who are slightly older, greater than 50 years, or have significant vascular risk factors or headaches to avoid misdiagnosis, which often happens in these groups. So this is the new suggested diagnostic algorithm for MS. We're not going to go over this, but as you can tell, it's only gone slightly more complicated than before. So changing gears a bit, what about treatment options? How have they evolved? So for primary progressive MS and secondary progressive MS, we only have one treatment option each, but the treatment options are very different for relapsing remitting MS. We had our first DMT introduced in 1994, and over the last few decades, this treatment landscape has really exploded, and now we have 15 disease-modifying therapies, or DMTs, in Ontario. So it can be quite overwhelming to even know where to begin in selecting a disease-modifying therapy. So how do we go about it? So there are a few basic principles in DMT initiation that are important to keep in mind with any patient. While MS can take a benign course, most often it does not. Although we've made major improvements in how we try to predict disease course, we're still not very good at doing it at the time of diagnosis due to limitations in our biomarkers and great variability in terms of the disease course between patients. So therefore, the vast majority of patients will benefit from treatment with disease-modifying therapy to help prevent long-term disability. We also know that the best time to start treatment with a DMT is early on in the disease course, as we've seen again and again that earlier treatment leads to lower disability scores in the long run and delays conversion to a more progressive course. So you can see in this graph here that those in the dark blue line who were treated early in the disease course, that was less than 1 year after diagnosis, compared to those treated 1 to 3 years after diagnosis, purple line, and compared to treated more than 3 years after diagnosis in the light blue line, those who were treated early were less likely over time to reach a higher disability score of EDSS of 4. So how do we go about selecting our MS disease-modifying therapy? There are many things that we keep in mind, and no two people with MS are the same. So we have to individualize our treatment choices. Traditionally, we've been looking at factors that can help predict more aggressive disease to help us decide if we should use a lower efficacy treatment or high efficacy treatment. These factors can be demographic factors such as male gender, older age, and cardiovascular risk factors, which we know predict more aggressive disease. It can be clinical factors such as more frequent or more severe relapses with poor recovery, or MRI features such as higher lesion burden and involvement of the spinal cord. There are many other factors to consider, though, when we select our treatment. Patient preferences plays a big role in terms of the convenience of the treatment, the route of administration, whether it's an injection or a pill. Insurance coverage to a certain degree does play a role. And then there are MS disease factors, as we just went over. And other things that we also look at is, are they older? Do they have other comorbidities? Are they likely to adhere to the treatment prescribed and the monitoring blood work that's required? And are they planning a pregnancy soon, as many of our DMTs are not safe in pregnancy? Another thing that has evolved recently is that we've learned that not only does treatment, early treatment, provide long-term disability outcomes, but we also know that it's better to treat early with a high efficacy therapy. So there was a landmark study that you can see on your left in 2021 that compared early use of high efficacy therapy in the bottom blue line to later use of high efficacy therapy in the red line. And this found a 76% risk reduction of disability worsening with earlier use of high efficacy therapy over 8 years. Similarly, another study that you can see on the right compared patients in Sweden in the yellow lines who were mostly treated with high efficacy treatments, as they do in Sweden. And they compared this to patients in Denmark who were mostly treated with lower efficacy treatments. And they found that over time, the people in the Swedish cohort did better, as they were the ones, again, who were on the high efficacy treatments. So the thought behind this is that that MS is the most active in terms of its inflammation and disease activity early on in the disease. So you really get more bang for your buck by treating early and hitting hard. So because of this evidence, we have really witnessed a major shift in how we treat MS in the last few years. So initially, we were using this escalation approach where we started with a low efficacy treatment, and then if they had a breakthrough disease activity, we would escalate the treatment to something stronger. But we've flipped the pyramid, and now we are using high efficacy treatment in many patients from the get-go after their first relapse when they're being diagnosed. Another reason why we're able to do this is because we've achieved an optimal risk-benefit profile of our newer DMTs. So if you look at this graph, you can see that safety is plotted on the x-axis, and on the y-axis, we can see efficacy. So obviously, ideally, you'd want to have a treatment that's somewhere here in the top right corner, because we have to balance efficacy with safety. Early therapies were considered very safe, but not very effective. We then developed DMTs with fairly good efficacy, but moderate safety profile. Then we got some very strong induction therapies that were highly effective, but not very safe. We then really, we realized then later that natalizumab, that was initially thought to be safe, actually could cause a severe brain infection known as PML, especially if you were JC virus positive. But in came the B cell therapies, and these were monoclonal antibodies that target and deplete B cells that have allowed us to achieve this perfect balance between safety and efficacy. And that has led to that paradigm shift of, instead of the escalation approach, we're now starting off with high efficacy treatments such as our B cell therapies right away. So why is there an interest in targeting B cells? The traditional view was that MS was mostly a T cell mediated disease, with B cells being relatively passive players. But we know now that B cells do play a big role in a complex network with bidirectional interactions among different B cells, T cells, and myeloid cells that eventually provoke the development of MS attacks and progression. So B cell therapies have come to represent a new era of MS treatment. They have been proven to be incredibly effective at reducing relapses and MRI lesions. They're very well tolerated and safe. They're fairly convenient, and patients like them. They're also the first treatment approach proven to protect against disability worsening in primary progressive MS, and the only treatment option that we have for this kind. So we were initially using rituximab, which is a chimeric monoclonal antibody. Then we developed ocrelizumab, which is a humanized monoclonal antibody. And then most recently, we've gone ofatumumab, which is fully human. So we thought before that most of patients' disability was coming from their relapses. So you can see here, this is x-axis time, and y-axis their EDSS score, which is their disability. So worsening disability as you go up the y-axis. So we thought that, you know, they would have a relapse, and then they may not completely recover, and then they would have another relapse and not completely recover, and eventually they would accumulate disability that way. So we thought that if we could only suppress these relapses with high efficacy treatment, patients would be completely stable and be relatively free of disability, at least for a long period of time. So this is what we thought would happen. But what we actually saw was something a little bit different. So despite excellent suppression of relapse activity, we've seen this relapse-independent silent progression that's been uncovered by these high efficacy treatments and was previously obscured by attacks in relapsing remitting MS. And what we've come to realize is that people with MS can accumulate disability in two ways. One is by relapses with incomplete recovery or relapse-associated worsening. As you can see on the left, the green part is the EDSS profile or the disability. So they have a relapse and then they may recover to some extent, but they still have some disability, more so than they did at their baseline. And the other way that people can accumulate disability is through something called progression independent of relapse activity, which can occur during periods of free of relapses. So you can see here, this is a relapse, and here in this blue, you have another relapse, and you do see progression with worsening of their disability in between those relapses. We now know that progression independent of relapse activity, or PIRA, is actually the main driver of disability accumulation in MS, in all types of MS, and it can be present very early on in the MS disease course. The DMTs that we have today They mostly target relapse-associated worsening, with the B-cell therapies to some extent being able to treat PIRA. But there obviously is a strong need for medications that can target both relapse-associated worsening and PIRA so that we can reduce disability in the long run. So what does the future hold? There are several DMTs in the pipeline that seem to be able to better target PIRA as well as relapses. One of the molecule class of interest is Bruton's tyrosine kinase inhibitors, BTK inhibitors that many of you have heard of and are used in other fields. They're interesting because they're able to penetrate the central nervous system, which our current DMTs cannot, and they can target inflammation on the other side of the blood-brain barrier. And this seems to be able to impact PIRA to a greater degree. But what about the damage that has already been done? Can we turn back the clock on MS? So there have been several phase 2 trials looking at remyelination strategies, which is, of course, of great interest. Some of the drugs that have been looked at have been clemastine with even metformin recently, bixaritine, but the results so far have been modest and haven't been clinically relevant. So that's something that's currently still being explored a lot. And then various neuroprotective drugs have been studied as well, including biotin and hydrosimvastatin, which were both negative trials. GLP-1 receptor agonists are, of course, the hot drug on the market, and they're slowly making their way into the MS world as well. They've shown some anti-inflammatory and neuroprotective effects, which makes them promising potential treatment options in MS. And we have seen some success so far in animal models, but this is being further explored. So finally, to finish off with, what are some things that the non-neurologist should know about MS? First of all, not every white matter lesion in the brain is MS. Radiologists often like to list MS on their long list of differential diagnosis, including white matter ischemic disease, demyelination, vasculitis, etc. But we as MS neurologists, we carefully scrutinize every single lesion on the MRIs that we're looking at, and we look to see whether they do actually have a typical appearance of MS and if they're in the typical location that we're looking for. And oftentimes they're not. Oftentimes these white matter lesions are just related to small vessel ischemic disease in slightly older people or migraines or other factors. So it's just important to keep that in mind. Even in patients with MS, not every symptom is necessarily MS related. Patients with MS typically do have other comorbid diseases such as depression, anxiety, and so on. And they can also have other autoimmune diseases that can cause different symptoms such as fatigue, numbness, and pain. So it's important to take that into the whole context when you're seeing these patients with new symptoms. And finally, we don't expect you to diagnose MS. But we hope that maybe you can try to recognize a demyelinating syndrome and have a high index of suspicion. And this hopefully will prompt you to order an MRI brain and spinal cord with contrast to help with that initial evaluation, which saves the neurologist a lot of time by the time that the patient's actually seen by them. Checking blood work for the patient's vaccination status and vaccinating if necessary is also helpful because for our patients, we do try to vaccinate them before we start a DMT, as it's either not safe to vaccinate them afterwards if it's a live vaccine, or the vaccine will simply just not be as effective. So that can also save a lot of time. And then finally, refer early to the MS clinic. If it's a more urgent, of course, let us know it's more urgent. We do sometimes have a long wait list. And in that case, you could refer the patient to a general neurologist in the meantime who can start the workup, which is also very helpful. And then as you're seeing the patient, there are several things that you can do on your own. So you can encourage vitamin D, 4,000 units daily, which we know is helpful to slow down MS progression. We do know that worsening of MS is linked to vascular risk factors like smoking, obesity, diabetes, etc. So trying to control those is very helpful. Encouraging exercise and physiotherapy as needed. And then we often get asked by patients about a specific diet for MS, but the truth is that There's no specific diet that's published that we know of, despite what you'll read on the internet. But a Mediterranean diet that's well balanced is good. And then you can refer patients to the MS Canada website that has a lot of helpful information. So in conclusion, we've come a long way with our MS diagnosis and treatments, and patients do live a very normal life. We've made a lot of advancements, not just with diagnosis, but with neuroimaging tools and other diagnostic tools to help us with an earlier diagnosis. We've introduced safer, more effective treatments that have led to this paradigm shift and flipping the pyramid, so that we're now treating patients earlier and with high efficacy treatments from the get-go. We've been able to achieve a significant reduction in relapse activity and some delay in disability progression. And now we're seeing that the high efficacy treatments in MS have unveiled the silent progression that is still the main driver of disability. And so, of course, there are still unmet needs that we're exploring at this time. And with that, I'd like to thank you all for your attention. I'll be happy to take any questions.
Thank you so much, Dr. Salmon, for this fantastic overview. Lots of evidence to look at. And I love the message at the end for the general internist or the general internal medicine specialist, dealing with those patients. I'm going to actually start with a question, but before I go, I'd like everyone, as usual, put your question in the Q&A. If you have any question, or in the chat, we'll keep an eye on it. And if you want to have your question asked in person, please raise your hand. I'd like to ask one question related to referrals, Jackie, and you did mention that, if it is urgent, let us know. What should I be looking at as an internal medicine specialist? So what's the urgency piece of? What are the things that would make it urgent, other than the active disease that actually may land the patient, directly in your clinic or in hospital?
I think that's
Dr.
Yeah, no, I think that's exactly it. You said it yourself, someone who has active disease, because we do get a lot of referrals for patients who maybe have incidental white matter lesions on their MRI. That's, that they've been doing fine. They're relatively stable. Maybe they have a few symptoms that haven't progressed. Those are the less urgent patients that can wait a little bit longer. But the young patient who had an optic neuritis and then 2 months later they had a spinal cord relapse, those are the patients that we want to see more urgently. Or someone who's had, progression and worsening of their gait for the last year and are now having more and more difficulties walking, that would be more urgent.
Fantastic. Jackie, if you want to stop sharing your screen, that would help you become bigger on the screen, so our attendees can see you better. And I will get Dr. Hallberg in, and I will leave it then to Dr. Salas to continue to facilitate.
Was there a question from, you said,
Yeah, I just had to wait for the unmute. Thanks very much for the review, Jackie. So I don't think we've met in person, but I'm clinical pharmacology and do quite a lot of work on policy. So the MS drugs have been of interest for many, many years, as you can imagine. We have quite a significant population and they're expensive. So the last CADIS review, so our health technology review, my understanding, it wasn't part of the review per se, but my understanding was the conclusion was that the newer drugs look to be quite efficacious, not a huge amount of concerns about adverse effects, but really the outcomes, they could not say about relative cost effectiveness because a lot of the key outcomes were missing, in particular quality of life. And they actually didn't think that even disability was that well documented, potentially over the long term. But I remember the thought being that there were two pragmatic trials about to finish. I think one was called Treat or Deliver, but there are some large trials apparently doing what they thought was more high quality comparisons. I just wondered if you had comments around the high quality evidence and what are we going to see in the future that's going to be very helpful, to decide about pathways for the medications.
Yeah, I mean, sometimes these CADIT reviews and decisions are a little bit arbitrary. We don't always agree with them, as you can imagine. So, of course, things like quality of life are not always reflected in the clinical trial data that we have. We're looking more at efficacy and safety, which is important. But yes, you're right. There are some, studies that are looking more at, quality of life. And we have a lot of the open label extension studies that are following patients years out on these therapies, because when they're newer, we don't always know in the long term how patients are going to do on them. But we are seeing promising results every year with our newer, the B-cell therapies that we're using, that over time there's still no adverse signal for safety, and that patients are continuing to do very well on them. That being said, there's still several unanswered questions about how to use these medications. Like, how many years do we keep patients on medications for? When can we stop these medications? That's not entirely clear. So still a lot that remains unanswered.
Yeah, so quality of life at the moment is really the only way that you can arbitrate across many diseases, and it actually turns out to have very valid outcomes. Just as a follow-up, could you comment on the average cost of a disease-modifying new therapy per year?
Yeah, that's a good question. I mean, they can be pretty expensive, so tens of thousands, if not sometimes hundreds of thousands. Fortunately, we do have very good coverage in Ontario for the vast majority of these, where they're either covered by the government or patient has private insurance and is able to cover them. But there are some specific cases where it can be challenging. And unfortunately, one of the things that limits us is also their disability status. So if they are beyond the use of being able to use a walker, say they're in a wheelchair, they don't qualify for any of the disease-modifying therapies. So that can be really challenging.
Yeah. Thank you.
Any other questions? I think it's ironic that you mentioned referral to general neurology. I think it's probably easier to be seen in the MS clinic than to find someone to take an undifferentiated neurology patient. We have so many subspecialty clinics, which is good, but the undifferentiated patient, it can be very hard to find somebody to see them if they don't fit into a particular clinic. What's the wait time right now for the MS clinic? I mean, we've made tremendous gains with our latest recruit. Can you share any recent numbers with us, Jackie?
Yeah, so I mean, it still can be up to 1.5 years if they are someone who's, again, been kind of stable, maybe incidental white matter lesions. But we do try to triage the patient referrals in terms of urgency. And that's why I mentioned that it is important to mention that, because if someone really needs to be seen, we can get them in within a few weeks. So we're pretty good at doing that. The general neurologist comment was really actually more for the community, probably, which maybe doesn't apply as much for everyone here. But we do see a lot of MS patients who have been seen by general neurologists in the community, because out in the community, it is even harder to get access to the MS specialist. And a lot of neurologists who were treating MS have retired, but we do still have general neurologists who feel comfortable working up these patients and at least making a diagnosis, perhaps not starting the treatment, as of course things have gotten more complicated, but it is still very helpful.
Now, Dr. Tallman has advised me that there are questions in the chat, but for some reason I cannot see them. So why don't we go to the chat?
Yeah, I'll help with that.
Sure.
Jim. So there's a question from Dr. Mirza around, I mean, everyone is thanking you for the great presentation, by the way. Can you tell us a bit more about remyelination strategies in terms of mechanism of action and what's the anticipated efficacy?
Yeah, so I mean, the thought behind this is that you have these oligodendrocyte progenitor cells that are supposed to be able to help regenerate this myelin that has been damaged. And there are different ways of doing different drugs that can stimulate these OPCs to stimulate remyelination. Now, in terms of the efficacy that's been seen so far, it hasn't been great. Like we've seen significant differences in some measures, such as visual evoked potentials that has been done for visual function, but then we haven't seen any really translation into clinical efficacy. So when they've actually looked at visual function or disability scores, they haven't seen any change. So really modest so far. And, of course, we anticipate hopefully greater, more efficacious results, but it's hard to say at this point.
Thank you. There's another question about how do you identify pseudoflures? It's reference to some symptoms that were labeled as pseudoflures by a neurology or by an MS specialist, not recurrence, and the fact that this is due to low reserve. So what are pseudoflares and how do you identify them?
Yeah, that's a great question. So we see that a lot. What does a pseudoflare mean? So patients who've had a previous relapse, similar to patients who've had a previous stroke, can have worsening of their symptoms like recrudescence in the setting of something like infectious illness, or even just stress or fatigue can bring up their old symptoms. And sometimes it can actually seem very similar to a new attack, but usually, it's the symptoms are similar to what they've had in the past, so they're not different. And even though people can have, say, if they've had an optic neuritis in the past, they can have recurrent optic neuritis. That's where we have to think about, okay, well, are there any signs of infection? We usually do like an infectious workup first to see if there's anything else we can figure out. We bring in the patient to see whether we find any new neurological worsening on their exam that's objective. And the time course can help a little bit too. Sometimes with a pseudoflare, it's a little bit slower in onset as well, and seems to correlate more with these other factors. So it can be tricky to differentiate. And then, of course, if you're not sure, it's important to get an MRI of the area that you're concerned about with contrast, because then you can look to see whether there is a new lesion that corresponds with that.
I see that often in MS patients who comes in with acute illness to the medicine service, and turns out to be just because of the infection or whatever.
Exactly.
There's a question about whether we should monitor CBC closely with patients on disease-modifying agents, looking for neutropenia. Is that something is usual practice, or what should be done in terms of the clinicians' work?
Yes, yes, we do. For the vast majority of our DMTs, we do monitor CBC, almost all of them, because they do have a risk of not as much neutropenia. One of them does, but we tend to see more lymphopenia with most of our drugs. So we do look for that usually every 6 months or so monitoring.
Dr. Dorsami is asking about a presentation referred to as Devek's disease, which is neuromyelitis optica, in relation, which relates to tuberculosis. Do you screen your patients for tuberculosis before you diagnose them with MS?
Okay, yeah, that's interesting. So I'm not aware of a specific relation with tuberculosis for neuromyelitis optica disease or Devek's disease. Perhaps you could tell me more if you know something else. But what we do know is that sometimes patients on certain disease-modifying therapies, they can have an increased risk of reactivation of TB in people who have latent TB. So that's really more where the risk comes in. It's not so much as related to MS development that we know of. So for certain disease-modifying therapies, we do have them do a TB test before to make sure that they don't have latent TB. Sometimes we're surprised by what we find.